So androgen replacement therapy. The treatment aims are to improve the libido and sexual function, improve mood and well-being, improve muscle mass and strength. Testosterone has a direct anabolic effect on the skeletal muscle and has been shown to increase the muscle mass and strength when given to the hypogonadal men. Lean body mass is also increased with reduction in the fat mass. It to prevent the osteoporosis. Hypogonadism is a risk factor for osteoporosis. Testosterone inhibits bone resorption, thereby reducing bone turnover. Its administration to the hypogonadal man has been shown to improve the bone mineral density and reduce the risk of developing the osteoporosis. Androgen replacement does not restore fertility. It suppresses the normal spermatogenesis. Men with secondary hypogonadism who desire fertility may be treated with gonadotrophins to initiate and maintain spermatogenesis. Prior testosterone therapy will not affect fertility prospects, but should be stopped before initiating gonadotrophin treatment. Male with primary hypogonadism will not respond to gonadotrophin therapy and may require donor insemination. So the indications for treatment are in primary in male with established primary or secondary hypogonadism of any cause in which testosterone is indicated. Treatment should be taken slowly with prolonged and severe hypogonadism. So weight reduction is associated with the rise in testosterone. Pre-treatment evaluation is necessary. First of all, clinically, we should ask in the history and about the symptoms of prostate hypertrophy, breast or prostate cancers, cardiovascular disease, and sleep apnea. So most importantly, if there is a history of cancer, be it breast or prostate, any enlargement of the prostate, sleep apnea, and cardiovascular, these are the things which can exacerbate with androgen replacement therapy. Examination would include rectal examination for the prostate and breast examination. Laboratory evaluation include PSA. It is important to note that PSA is often low in hypogonadal male, rising to normal age-matched levels with androgen replacement therapy. Hemoglobin and hematocrit as testosterone is associated with polycythemia, and cholesterol profile should also be checked. So the contraindications for androgen replacement are there are absolute contraindications and there are relative contraindications. The absolute contraindications are cancers, that is the prostate cancer. The other one is breast cancer. The relative contraindications include benign prostatic hyperplasia, polycythemia, and sleep apnea. And monitoring of therapy should be done 3 months after initiating therapy and then 6 to 12 monthly. Clinically, these patients should be evaluated for the relief of symptoms and of androgen deficiency and exclude any side effects. Serum testosterone should be measured before the next dose. Rectal examination of the prostate if the patient is more than 45 years of age. PSA should also be checked if the patient is more than 45 years of age, and hemoglobin and hematocrit should be checked to rule out any polycythemia. And serum lipids should also be checked during the evaluation. So the risk and benefits of androgen replacement therapy. Prostatic disease. Androgen stimulates the prostate growth, and testosterone replacement therapy may therefore induce symptoms of bladder outflow obstruction in male with prostatic hypertrophy. It is unlikely that testosterone increases the risk of developing prostatic cancer, but it may promote the growth of the existing cancer. It may be possible to consider testosterone therapy after 4 years in the low-risk patient with prostatic carcinoma after restaging and with careful PSA surveillance. So in patient with a history of prostate cancer, it can be considered after 4 years after restaging and PSA surveillance. Testosterone stimulate erythropoiesis. Androgen replacement therapy may increase the hemoglobin levels particularly in the older males. It may be necessary to reduce the dose of testosterone in male with clinically significant polycythemia. As far as the cardiovascular disease, testosterone replacement may cause a fall in both LDL and HDL cholesterol, the significance of which remains unclear. The effect of androgen replacement therapy on the risk of developing coronary artery disease is unknown. Other side effects would include acne. Gynecomastia is occasionally enhanced by testosterone therapy, particularly in peripubertal boys. This is the result of conversion of testosterone to estrogen. Fluid retention may result in worsening symptoms in those with underlying congestive cardiac failure or hepatic cirrhosis. Obstructive sleep apnea may be exacerbated by testosterone therapy, hepatotoxicity with oral 17 alpha alkylate testosterone can also occur, and mood swings are associated with this condition. So the preparations are testosterone preparations are IM testosterone esters. It is given 250 mg every 2 to 3 weeks. Monitor pre-dose serum testosterone level, and it should be above the upper limit of normal. Advantages are 2 to 3 weekly dosage. It's effective and cheap, and it's contraindicated in case of bleeding disorders. There is wide variation in the serum testosterone levels between injections, which may be associated with symptoms. Testosterone implants, which are given in the dose of 100 to 600 mg every 3 to 6 months, and monitor pre-dose serum testosterone. Physiological testosterone levels achieved, and the dose is 3 to 6 monthly. Minor surgical procedure is needed in these for these implants. Risk of infection and palate extrusion is present. Must remove the palate surgically if complications of androgen replacement therapy develops. Transdermal transdermal gel, and the dose is 5 to 10 gram gel per day, and the physiological testosterone levels achieved is convenient. Possible person-to-person transfer can occur with this route. Oral testosterone, it is highly variable efficacy and bioavailability, and buccal testosterone can also be used